Okay, welcome to this week's lecture of week 1 with your crash course in basic resuscitation and stabilization of a newborn following their delivery. So today we're going to kind of talk, and let's start with the basics that you're going to see primarily during your resuscitative effort. So the first thing we're going to kind of talk about is just a little bit of a review of the Academy of Pediatrics. Really kind of gives some good guidelines on what type of infants usually end up needing some kind of resuscitation. You can see in the very first line that about 10% need some level. Some usually refers to those that might just possibly need some positive pressure ventilation to help them begin breathing. A lot of times, if they're a vaginal delivery, they get the squeeze that they need to kind of help increase that thoracic pressure in order for them to help take that deep breath. And we all know sometimes in C-sections, when the baby comes out, they're going to need help getting that big breath open. So usually just some sort of positive pressure ventilation helps get them going, and then after that they usually don't need any more ongoing or extensive resuscitation, which you see next would be about less than 1%. Usually what happens here is the heart rate stays below 100 even with effective positive pressure ventilation. And what you're going to need to do is then intubate, possibly even chest compressions, and then may end up leading to some sort of medication administration during the resuscitation. And then usually those infants end up in the NICU for some ongoing stabilization, and then further just watching them a little bit further, making sure they can turn around from whatever disease process that may have caused the 1% needing to have the extensive resuscitation. So the first thing we're going to talk about the equipment that's going to be necessary for this class. This is where your first assignment's really going to kind of come into play, which is going to be your icebreaker, which is the scavenger hunt. In the scavenger hunt, the point of it, I know it's a little silly, but the point of it is going to be just to kind of get familiar with the NICU, familiar with the labor and delivery department, and familiar with the equipment that you're going to have in order to have a good resuscitation. So the first thing that you're going to have is going to be an overhead open radiant warmer. And we want to make sure that it's pre-warmed, not cold, because we all know that, cold's never a good thing. Crash cart. And within the crash cart, you usually have all of your major supplies that you need for medication administration, your epi, your dopamine, anything like that that might be your medication side of things. Appropriate supplies for correct gestational age. So we all know that really intubation, or we're going to talk in a little bit about different intubation supplies based on gestational age, weeks, weight. So we need, your intubation supplies, which usually consist of your blade and handle, and then you have your ET tubes, suction catheters, and then of course your ambu bag. You're going to need warm blankets because you always want to be sure that you take off the wet and dry prior to adding more warm blankets. Every labor and delivery room and C-section room has a built-in oxygen source with a blender, so we can titrate oxygen all the way from 21% up to 100%. And then of course the main thing, let's talk team members. Team members are usually going to consist of a respiratory therapist, a nurse, and then a physician. Sometimes a physician may also be a nurse practitioner depending on the gestational age of your patient. So here we can talk a little bit about personnel, and the behavioral skills that you need are always going to be, can you work together as a team? You always want to know that it's teamwork. There's not an I in team, just like we learned when we were in T-ball way back, when we were doing that, back when we were little. But teamwork, leadership, communication, those are all great skills to have amongst your team, especially when the resuscitation goes into that extensive resuscitation where you're going to need to be able to call on those people to help you get into the next step. You want to be sure that they are very attentive to what's going on, and that of course they always maintain that professional behavior during the resuscitative effort, because you never know who is listening or who is going to be watching. So you just want to be sure that you maintain the professional behavior and maintain the professional attitude that you need to have. Yes, we all are going to get down on ourselves and down on our team, which is very normal, but just remember that you're working together for positive resuscitation and stabilization of this family's newborn. So the first three things that you want to do as soon as the baby's presented to your preheated open warmer, here we're talking about that again, is dry, warm, and stimulate. Those are three primary things that are going to start your basic resuscitation. Dry with those pre-warmed blankets, warm them with the pre-warmed blankets, cover that hat or cover the head with a hat, because it is a known fact that newborns head surface primarily is the largest surface to area ratio, so that's where they're going to lose a lot of their heat. And while you're drying and warming, you're going to want to stimulate. See how the baby is able to react to their heart rate, how they're able to react to the, are they able to maintain active respirations? And we'll go into that a little bit more here in a few minutes. The strategies for resuscitation, so we want to dry our infant, so we reduce evaporative heat loss. We all know that there is going to be some sort of evaporative heat loss, usually through insensible water loss in a newborn, which is usually through your skin and your respiratory tract. So that's why it's important to dry your infants. Place of the infant on a warm blanket. So let's stress warm here. We don't want to stress cold. So if we place them on a cold blanket, you're going to end up with some conductive heat loss. So you want to place them on a warm blanket. You want the preheated radiant warmer. We want to make sure that it's not turned off. It is turned off. Please turn it on and crank it all the way up to high as soon as you get in either the labor and delivery rooms or the C-section rooms, and protect them from air currents, which reduces convective heat loss. The main way that we protect from the air currents is usually the marker of about 28 weeks and less. We will place the infant on a set of warm saran wrap and wrap them up so all the wetness stays within the saran wrap, because it has been known if you wipe off the wet off of a less than 28 week gestation infant, they usually drop their temp very quick, and that's really not what we want to do. So if you see this cute little picture down here in the corner, you've got the little newborn or the little infant, obviously maybe Russia, who knows, over in a pool. I'm hoping it's a warm pool, out and cold, so you know that's never going to be a good thing. So let's initially talk about your ABCs of resuscitation. They are very, very similar to your typical ABCs in CPR. You're going to ask yourself three questions when the baby comes out. Are they term? Do they have a good cry? And do they have good tone? And if they do, then you're just going to end up with your routine resuscitation, which is dry, warm, and stimulate. If not, you're going to go into the initial steps of resuscitation, which are going to start your A, B's, and C's. A, establish that open airway. You want to position the patient to where their chin is not on their chest or their chin and neck is not hyperextended. So usually a small roll under the shoulders helps with this. Then you're going to suction the mouth, then the nose, and then sometimes even the trachea, depending on if meconium has been present in the amniotic fluid. You want to suction your mouth and then your nose first. Remember, M becomes before N in the alphabet, because anything that possibly could be in the mouth, you want to get out, because if you think about suction in the nose first, they may end up aspirating the contents that are in the back of the throat, and we don't want to do that. And then intubate if necessary. So B, when it talks about initiating breathing, as you're dry, warming, and stimulating, you're evaluating, of course, heart rate and respirations. So you're going to provide tactile stimulation usually as you're drying. And tactile stimulation is just going to be simply rubbing the back as the baby is getting dried off, or flicking the bottom of the foot. You know, you see the old adages where the doctor lifts the baby upside down and spanks it on the hiney. No, we just provide tactile stimulation by vigorously rubbing the back or thumping the foot. And then provide positive pressure ventilation if need be by bag mask or otherwise intubating through your endotracheal tube. C, circulation. Usually if you initiate B, then will come C, will maintain and follow by itself. Usually that you don't usually get into maintaining circulation, because once breathing occurs, ventilation usually leads to, positive circulation as well. But if that heart rate stays less than 60, despite adequate positive pressure ventilation, remember the little key there, less than 60, despite adequate positive pressure ventilation, then you're going to do chest compressions. And then if that doesn't, help the situation, then you'll get down into medications. All of this we'll talk a little bit more in depth in each different area. So evaluation, well, let's talk a little bit about the respiratory effort. If the brief period of tactile stimulation doesn't help the baby take the big, deep breath that it needs to in order to, start maintaining adequate, effective respirations, you might see some gasping or even apnea. And if the tactile stimulation doesn't work, then you're going to move into positive pressure ventilation. So you're going to be watching and, evaluating the respiratory effort and the heart rate the entire time. So with your heart rate, once your heart rate gets less than 100, 100 is key here, because if you get less than 100, you're going to begin to positive pressure ventilate. And where you're going to feel, you can see over here in this picture, 2 ways of evaluating heart rate. The one person that's back within the picture, you can see here, they are holding the umbilical cord, because remember, for about the first 10 minutes of life, the baby is in fetal circulation. So you can still feel the pulse real well through the umbilical cord. And then also another practitioner is going to have a stethoscope as well to listen over the heart on the left side of the chest, to also listen for and evaluate heart rate as well. So respiratory effort and heart rate are the 2 primary things that we're going to talk about or pay attention to during your basic resuscitation. Okay, so remember, let's go back just a minute. We're going to talk about dry, warm, stimulate, and then evaluate. So dry, warm, stimulate, evaluate. Evaluate that respiratory effort, evaluate that heart rate. In an ongoing effort, sometimes you're going to put a pulse ox probe over here on the patient's right hand, and that's going to kind of let you know how are we doing with, do we need to treat with oxygen. So just remember, usually till about 10 minutes of life is when they start getting adequate sats for their size. So you may need to treat the patients with oxygen if it doesn't look like they're coming around. Positive pressure ventilation. So here is our practitioner giving you a little bit of a heads up on the best position to have it. I wish I could find a little bit better slide to show you, but this just shows a good bag mask ventilation right here. You see that they're holding the mask effectively over the top of the nose and down underneath the chin. You always want to be sure that you have an adequately sized mask for your patient, never too big, never too small. So your indications for positive pressure ventilation are going to be apnea or gasping respirations, and then your heart rate less than 100. Here we talk about heart rate less than 100 again. This is key. That's why you're going to see it mentioned quite a bit. Depending on the gestational age of the patient will depend on how much oxygen you begin resuscitating with. The Academy of Pediatrics states that usually 36 weeks and greater to your term, you can really begin resuscitating with 21%, because all they need is the pressure to get the chest expansion to help getting them going. And then here we talked about the fitting mask, which we went over, and then the functioning bag, either flow-inflating or self-inflating. The main difference between the two is flow-inflating is going to require a gas source, whereas self-inflating is not. This is the type of a self-inflating bag. Usually flow-inflating bags they use in the OR on anesthesia machines. So you want to give usually and initially a high pressure 30 to 40 centimeters of water. There's a pressure manometer built into the top of the ambu bag, so you're able to see the amount of pressure that you're giving. And then you just want to be sure that you assess chest rise. If you're not getting chest rise and your heart rate's not responding, you might either need to, 1, give more pressure, or 2, is the mask appropriately fitting. So you want to bag at what their normal respiratory rate would be, which was between 40 and 60 breaths per minute for about 15 to 30 seconds, and then you're going to be evaluating again. Now, the entire time that you're giving the positive pressure ventilation, you're still listening and feeling for that heart rate, because that's going to let you know if it's been effective. If you've had to bag for, a prolonged period of time, you might want to ask the nurse to put down an OG orogastric or NG nasogastric tube. And what that does is that goes into the belly and helps release some of the air that has been given into the gut, into the belly by positive pressure ventilation. Because just remember, anything's going to take path of least resistance, and the esophagus is a lot more compliant than your trachea, so air is going to get in your belly first. And if your belly starts getting big and distended, then you're going to need to pull that air off so you can get effective ventilation. This kind of shows you here how it is to hold the mask over the patient's face, and this kind of shows you right here the pressure manometer dial that we talked about a little earlier. So going back to correct positioning, neck slightly extended. If you usually roll up one of the small blue towels or even a diaper, if a diaper is readily available, that's usually good enough to allow for adequate extension of the neck. And then talking about your masks, here's good mask placement, bad mask size because it's too small, bad mask size because it's too big. Mr. SOPA is a nice little acronym that they gave up for mask readjustment, reposition, suction the mouth and the nose, open the airway, because sometimes the babies do clamp down, increase the pressure if you're assessing that there's not good chest rise, or always intubate if necessary. Mr. SOPA is one of the newer things that they talk about in the neonatal resuscitation program, and that's also in one of your activities this week, is to kind of go over the NRP book and look through it, and also kind of know what their guidelines are in regards to all of this. So evaluating heart rate, we kind of touched on this a little bit already, is you want to make sure you have a stethoscope, which you're going to be listening to right here, or the umbilical pulse, which you're at least going to feel for about the first 10 minutes because they're in the fetal circulation. And then here we are talking about our 100. 100 is our cutoff. Greater than 100, obviously we've had very good positive pressure ventilation, or the baby already came out with a heart rate greater than 100. So then obviously the heart rate's good, the baby's hopefully sustaining spontaneous ventilation. If the heart rate's between 60 and 100, you want to continue the positive pressure ventilation until the heart rate gets over 100. Here we talk about 100, 100, 100, 100, 100 A+, remember that. Less than 60 despite 30 seconds of adequate positive pressure ventilation, then you're going to start chest compressions. The main thing is going back, a little review is, are you getting good chest expansion with your positive pressure ventilation? Because if you're not getting good chest expansion, then obviously something may not be right. And then it could also go back to our Mr. SOPA. Is there something in the mouth that we need to suction? Is the mask of the appropriate size? Or do we just need to go ahead and intubate our infant? There's two different ways that we're going to talk about chest compressions. I know this doesn't have a picture, but I have it on the next page where we can talk about it a little bit. You want to do it in the lower third of the sternum, just below the nipple line, and you want to compress 1/2 to 3/4 inches, which is about 1/3 the depth of the chest. Usually in a very elongated resuscitative effort, you have two people swapping out doing chest compressions, because your fingers do get very tired very quick. And here you want to discontinue doing chest compressions if your heart rate gets over 80, but then if it goes back down again, we'll want to restart compressions. So there's two different forms of doing chest compressions. You have a 2-thumb method and a 2-finger method. The 2-finger method is long kind of since been gone by the wayside. A lot of facilities are doing the 2-thumb method downstairs in the delivery, or even at patient bedsides now. Because what happens is, say you've needed to intubate your patient, well, you have the person at the head of the bed that's doing positive pressure ventilation through the endotracheal tube. So you have one person on the side of the bed doing the 2-thumb method. Well, what that does is that allows another person, if there is extensive resuscitative efforts needed, especially with medication, to give the medication through the umbilical cord. Usually in a delivery, you're going to hopefully see that there's 3 vessels, 2 arteries and 1 vein in the umbilical cord, and the vein is very big and very floppy. So usually in a delivery, you can see the vein through the side of the cord, and that's the vein, or that's the vessel that you'll end up cannulating in order to give medication. So if the person's doing the 2-thumb method, it's usually easier to get to that area of the patient versus the 2-finger method, because a lot of times there's somebody else on this side of the bed doing, stimulating, pulling up meds, or something of that sort, and then the person on the other side's doing the chest compressions. So the person who needs to put in the line through the umbilical cord usually can't get to that area. So just remember, 2-thumb method, 2-finger method, and as you're doing chest compressions, never let your fingers off the patient. Always make sure you're resting your fingers on the patient. Intubation, if you have prolonged resuscitative efforts where bag mask ventilation isn't working, it's not keeping your heart rate up, or if your heart rate isn't up, you're not maintaining spontaneous respirations, you're going to go ahead and intubate. You also may end up needing to intubate if there's presence of meconium in the fluids, and we'll talk a little bit more next week in the presentations about different scenarios where you're going to just need to go ahead and intubate as soon as the patient's placed on the bed. So this just kind of shows you here the practitioner holds the blade and handle in the left hand and then intubates with the tube in the right hand. Remember, all of this, you can try all of this in your simulation, which is the biggest assignment that you need to pay attention to this week. Simulation. Go utilize and practice in that NICU education room, because all the tools and everything necessary for basic resuscitation, intubation, chest compressions, your bags and masks, all of that is available to you in your NICU education room, along with several different size mannequins as well. So you're going to intubate and then do positive pressure ventilation. So talking about endotracheal tube sizes, the size tube that we're going to use for the patient is going to be based on the weight. It's going to be more based on the weight than it is the gestational age. If you have a patient that doesn't have a lot of prenatal care, we may have to estimate with the gestational age, and that may kind of give us a little bit better of a range. So if we talk weight, less than 1 kilogram or 1,000 grams, you're going to use a 2.5 ET tube. 1 kilograms to 2 kilograms, we're going to use a 3.0 ET tube, or 1,000 to 2,000 grams. Remember, we're going to say a lot grams and kilograms in the NICU because that's how we base everything, not in pounds and ounces. And then 2 to 3 kilos or 2,000 to 3,000 grams is going to be a 3.5 ET tube. The main note to remember here is you always want to have the appropriate sized ET tube and one size tube smaller, just in case the tube that is supposed to be the appropriate fit doesn't fit through the cords, because a lot of times the cords are still tight. As the baby is still in fetal circulation, the cords are still tight. So sometimes it's hard to get the appropriate size tube through the cords. So sometimes you have to go half size smaller, because the last thing we want to do is really damage the cords, because even short-term intubation can cause long-term vocal cord damage. So we really want to be attentive to that. So here we go, a little bit about an overview of what we've talked about. So this kind of goes over some objectives for your week. You're going to place the patient on the preheated warmer, and then here you see dry, warm, stimulate. Our first 3 things that we're going to talk about. And as you're dry, warming, and stimulating, you're going to come over here to this side, and you're going to evaluate respirations and your heart rate. Remember, 100 beats per minute is key. If you're not above 100, bag, and then evaluate that heart rate. And then it just kind of goes from there based on where the heart rate ranges are, and also if there's going to be some ongoing resuscitative efforts. And then once you begin to get into that stage of just evaluating, providing oxygen, are we observing, we're going to go back and we're going to start thinking of the APGAR score. In talking about the APGAR score, there are 5 different things that encompass the APGAR. A, appearance. P, pulse. G, grimace. A, activity. And R, respirations. So each different category, since there's 5 categories, each different category is going to give you a 0, a 1, or a 2. Of course, 2 being best, 0 being the worst. So the main thing we're going to see is we're going to do APGARs at 1 minute, and we're going to do APGARs again at 5 minutes. Because we all know that when we get to the 5-minute mark is usually when we're getting close to maintaining adult quote-unquote circulation versus the fetal circulation. So that's a couple things that we're going to need to, remember, is talking about that and knowing, what the patient, how the patient's being assessed by the team. And yes, even that is a team effort, because one person may see one thing, one person may see the other. But you want to remember, it's a team effort. So we want to be sure that we collaborate and get together, especially if it's an ongoing resuscitation, when you really are going to have to go back and think, okay, well, at 1 minute, was the heart rate less than 100? Remember, 100 is key. 100 is right there where you need to be paying attention to. Respiratory effort. Remember, we're evaluating that heart rate and that respiratory rate as soon as we're, as we're doing the dry, warm, and stimulating. This is going to be one of the major keys of the assessment of the patient, and assessing, especially these term newborns. Are they going to be able to go to the newborn nursery just for routine care, or are they going to have to come to the NICU for ongoing care? So that is the end of this week's PowerPoint presentation. We're going to just talk a little bit real quick and summarize what we talked about. The equipment, which is going to be one of your assignments for this week. I would like for you to upload your resume to the clog just so we can see what everybody's background is, to kind of have an idea. Remember your questions and your quizzes. Look over your Academy of Pediatrics book to kind of know what the guidelines are for the neonatal resuscitation program. And of course, do that simulation. Practice, 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 because the more practice you can get, the more comfortable you're going to become with your team members and becoming an effective team member in the resuscitation and stabilization of a newborn. Remember, utilize your resources in the NICU. The staff in the NICU is a wealth of knowledge, so please feel free to ask them any questions, and also feel free to contact me if you have anything. And I hope this gave you a little bit better insight. And there's also a written lecture under the resources tab and also on your weekly module, so be sure to review that as well. I will see you next week.